What is up, future flight crew? My name is Jared Reedwood. I am one of the students here in this program. Today we're just going to take a little time out to talk about resuscitation in our trauma patients and our RSI patients and how important it is to address these concerns. So first off, managing hypotension and hypoxia in these trauma or critical care patients is very essential. Prolonged hypoxia or hypotension can lead to very poor outcomes, significant organ dysfunction, lower coronary artery perfusion. The lack of blood flow to the body can cause tissue ischemia, which can just lead to all other kind of issues. So it is super important for us to address these concerns before it's too late or before we do anything to just further decrease these hemodynamics and make things even worse than they already are. Things like that, intubation, procedures, induction of sedation, paralytics, anything like that can just harm our hemodynamics even more. So one tool that we can use to assess the need of resuscitation in these patients is what we call a shock index. The shock index is the heart rate divided by systolic blood pressure. If it's greater than 1, then we need to intervene. If it's less than 1, it's not. So kind of the dumb way I remember this is if your heart rate is higher than your systolic blood pressure, we need to do something, whether that be blood, volume with fluids, or if we need to administer pressors, push those pressors, whatever that needs to be. Also, hypoxia is a big one here. So do we need oxygen? Do we need a bag for a little bit longer? Do we need any kind of alternative airway? Do we need to do anything else before we proceed down this path? So first off, we're going to talk about resuscitation in the RSI cases. So in the ER, ICU setting, intubation is something that we do a lot. And hypotension and hypoxia can occur real quick, and it occurs too often. So some studies have shown that these hypotensive and hypoxic episodes are directly correlated with increased morbidity and mortality post-intubation. So if there's things that we can do to help prevent that, then, why wouldn't we do it? So many resuscitation courses are actually starting to introduce what we call DSI, which is delayed sequence intubation instead of RSI. The hopes with this is to kind of slow things down a little bit, and this allows the providers time to remember to do the little things that can really make a big difference. Those little things like proper positioning, making sure that we're going to get this intubation on the first try, making sure our blood pressure is good, making sure we got that good oxygenation, nitrogen washout, all the little things. It's just hopefully will allow us more time to think about those and correct those before we kind of follow through with this procedure. So the active intubation can actually alter your body's compensation mechanisms too. So introduction of positive pressure. That positive pressure we know can cause a significant drop in blood pressure. And then your induction agents, it's really important to make sure we're choosing the right induction agents because these induction agents can have a huge effect on your blood pressure and heart rate and all that kind of stuff. So in this little table right here that's on the PowerPoint, I was looking at a study, and it was showing us this group of people that did a study where they were looking at the incidences of hypoxemia, cardiovascular collapse, or cardiac arrest after intubation. Then they implemented a set of protocols, which was full of pre-oxygenation and taking care of pressure, making sure everything was to a certain standard before we intubated. And kind of what we saw here is before the protocol, there was a 25% chance of severe hypoxemia. After we implemented those protocols, that was down to 10%. Cardiovascular collapse was 26% pre-protocol, 15% afterwards. And then cardiac arrest or death went from 3% before to 1% after. So what we're looking at here, the kind of standards were pre-oxygenation. We wanted to pre-oxygenate for at least 2 to 3 minutes. This would allow time for that nitrogen washout, which ultimately allows more oxygen reserve, which ultimately allows us to oxygenate longer while being apneic. To do this, we're going to use bag mask ventilation. Hook it up to your flow meter, crank it up as high as you can. You can also add high flow to that or just regular nasal cannula. Again, just hook it up to the flow meter, crank it up as high as you can. Also, administration of fluids or push dose pressors. Volume is always a good option if that's the need, but the problem with volume is it takes time to actually cause its effect. So push dose pressors tend to work quicker, and they're a great bridge to get us there. So we're going to talk about those here in a minute, but first we're going to talk about resuscitation and trauma. Ultimately, it's the same indications as resuscitation, like with intubation. We're looking into the hypoxia, hypotension, all those kind of issues. So most trauma patients are going to present with hypovolemic issues. The fix to this is volume, whether that be blood or fluids. But again, it's like we just said, volume takes time to kind of kick in. So this is where push-dose pressors are a great bridge to give you that time for that volume to start working. And also, don't forget the little things, supply oxygen. A lot of these patients are going to be hypoxic, so whatever kind of oxygen we need to get us good oxygen, good perfusion, all that kind of stuff. So we're going to talk about 4 push-dose pressors real quick. We don't have much time left, so we'll try to kind of skim through it. The 4 are going to be epinephrine, phenylephrine, or neo, vasopressin, and levophed, or norepinephrine. So epinephrine is going to target our alpha and our beta receptors. So kind of quick on those. Alpha is vasoconstriction, beta 1 is increase heart rate, and then you have beta 2, all that kind of stuff. But this really is going to hit the alpha and the beta 1. So the way epi works is it's going to increase blood pressure by increasing heart rate and vasoconstriction. Some adverse effects here, tachycardia, hypertension. Then we move on to neo or phenylephrine. So this one only targets alpha receptors. So this one's great if your patient is already tachycardic and hypotensive. We can give neo because the neo doesn't hit your heart rate as much. So that's always good for it. But your neo is going to increase your blood pressure only with alpha, so vasoconstriction. Adverse effect obviously is too much, hypertension. We're also going to look at vasopressin, or also known as antidiuretic hormone. So this targets your V1R, V2R, V3R, and oxytocin receptors. And your V1R is kind of what helps us here. It's what causes vasoconstriction. So vasopressin increases your blood pressure by vasoconstriction and by antidiuresis. Another cool thing about vaso is it's also naturally produced by the body, so it's not necessarily as harmful. Then we're going to talk about norepinephrine, which is levophed. It pretty much works the same as epinephrine. It targets alpha and beta receptors. It increases your blood pressure by increasing your heart rate and by vasoconstriction. And also, if they're doing the study, just talking to people and looking at stuff, a lot of people really prefer push-dose levo just because a lot of nurses are more comfortable with it, because a lot of facilities and a lot of practices, this levo is first-line treatment for pressors for a lot of these physiologies. So the last slide is just kind of my references, and that is it. I hope I didn't take too much time of your day boring you with this information. Thank you so much.